Call the meeting to order. First item of business is approval of the minutes, which you all should have received. Any additions or corrections? Is there a motion to approve?
I'll make a motion.
Second?
I'll second.
All in favor?
Aye.
Aye. Opposed? Minutes are approved. We're going to skip the health officer report for the time being and move on to the clinical director report.
Okay. So I took our Health First Indiana subgrantee contracts to the commissioners, and this past week we got conditional approval from them with a few changes. So the commissioners recommended that we did fund the supervisory role with Reed. And then there were a few other kind of editorial changes that Ron recommended and that they approved. So one of those changes was that we used the legal agency name in the preamble, and then kind of use a reference name from there throughout the rest of the contract, which was a change that I made. You should all have a version of the contract in your folders that you can look at. I didn't think that it was necessarily a requirement to print all 800 pages of them for you to review, but you have a version of that to look at. And then there were a few other things, typos, a miss period, different bullet point structure, stuff like that. So all of those changes were made. So we're gonna need a motion to approve those today, but I wanted to talk to you a little bit about how I got to the structure of what we have now. So I took the skeleton of the Hamilton County grant agreement. So the Hamilton County had an interlocal agreement, a grant agreement, and an MOU, which we had seen either last month or the month before. And so I used their grant agreement because I felt like that was most appropriate for what we were going to end up doing. And then made relevant changes as far as Wayne County edits, so wording, timeline, terms, contact information, etc. And then I put all of the Indiana Department of Health and Health First Indiana data reporting requirements into the grant agreement. So Hamilton County didn't have that, and I felt like that was kind of important for them to agree to those data reporting requirements. And so in most of those contracts, it's about pages 11 through 14. Some of them are a little bit longer, a little bit shorter, but that's where you'll find that section that I added in from the Hamilton County skeleton. And then I created subgrantee specific versions from that. So kind of regarding their specific core service areas that they intend to service. And then I made, from there, that's what I presented to the commissioners, and then made the changes that the commissioners recommended. And then that's what you guys have in front of you today.
And one thing I want to bring up, the commissioners did have one significant recommendation on a change, and that was on the Reed contract. And what their concern was is that without supervising and who's going to write the reports and do all the statistics, that we're going to need to supply the state, which we're going to use to show whether we're meeting our goals or not. So they recommended very strongly that we reinstate that supervisor stipend. I think we overlooked the fact we were just thinking supervising the workers, but we didn't really think about somebody's going to have to compile reports, statistics, and everything to show that they're meeting or not meeting their objectives. So further discussion on that issue?
If it's helpful to know, their original proposal was $260,000, and what you approved last time was $238,000.
12,000 is the amount involved. So I've given Commissioner Gregory, and also that is Dr. Jetmore's recommendation. I talked to him also. So I would entertain a motion to reinstate that 12,000.
I'll make a motion to reinstate the 12,000.
Is there a second?
Second.
Okay. All in favor?
Aye.
Aye. Opposed? Okay, thank you.
So just to clarify, are you guys making a motion to approve these contracts for me to send them to the commissioners?
All we acted on was restoring Reed's supervisory,
Okay.
12,000.
So,
We haven't done anything on the others. Now, we approved all the others, subject to the approval of the commissioners before. And we've approved this addition, so do we need another vote to approve these contracts, or, I don't think so.
I don't know which ones you're talking about. You're talking about the 6 that I reviewed?
yeah.
No, there were no substantive changes other than the inclusion of the supervisory indirect cost component, which I didn't have that number, but I think you reviewed that.
Yeah,
Yeah.
260 and 238 is what the
Okay.
difference was.
So we,
And I think their theory was, sure, we can assume that somebody's going to supervise them, but we'd like to have discrete accountability as best we can going into all these contractual relationships. And I think rather than assume that Reed will be supervised, as I'm sure they would, I think it's a component of their original proposal, so I don't think it makes sense to take it out.
okay, so since we've approved these before, there's no, the one comment I had on the signature page, should we add the health officer?
Yeah, I can do that.
It now just has the clinical director from the department. It has commissioner, the auditor.
I didn't see anything abnormal about the signature page. What?
I can show it to you.
Well, for the department, it has clinical director. It doesn't have the
Health
health
officer.
officer. Is it okay just to leave the health officer off?
I didn't have them. Like I say, I didn't see anything significant about the signature page, so what's the concern?
The different signatures.
Now, the commissioners can easily sign they'll adopt it, and they approved them, but the signature of a single commissioner's fine, and the rest look fine to me.
So we don't need a health officer's signature on that.
Don't need a what?
We don't need a health officer's signature on that.
I don't believe so, I think.
Okay, I think it's okay the way it is. Okay.
I think that's fine. I have no problem with it. I mean, I assume he was part of the review process, was he not?
Yeah.
Yes.
Yeah.
And just for your reference, directly behind the copy of the contract is the copy of Ron's recommended edits, if you're interested in reviewing those.
Okay, so we've done the final contract approval.
Okay.
Reporting?
So, for reporting, the local health department core service status update was due on June 15th. And so what that is that's gonna be kind of your greenish tab here, kind of a mint green. And it's nice because they put it into a spreadsheet for us and they compare the first time that we reported and then our second time reporting. So they're 6 months apart. And you can see the dates up there at the top, that second row down. So the first time that we did it was March 4th, and then the second time that we did, this is supposed to be biannual reporting. They only made the due dates 3 months apart, I guess. But the first biannual report was due in March, the second biannual report was due in June. And so here you can kind of see the progress that we're making on the core services, which I think is really cool. You can see a lot of the ones in the blue column say not started. And then over here in the white column, you can see kind of more, farther along, we've got a lot of these things in progress, and that's, I think, due to our subgranting that we're working on. So I'm not necessarily going to go through all of this right now, but I think it's kind of exciting to see all the progress that we're making because of the subgranting that we've got going on. Okay, and then the next page that you have is this one. It's got the little map of Indiana on it. And the reason why I wanted to highlight this, so this is called the at a glance for the county scorecard. I actually made updates to this within the last 2 weeks or so. It should have been directly behind your spreadsheet.
There we go.
Maybe we were clumped together, yeah.
Here.
You remove the paper clip.
Yeah, I should remove the paper clip.
I did.
Okay, hold on. And you're directly behind. I didn't know that. This is different, no?
Oh, that's all right. That's okay.
There it is, there it is, there it is.
They're hiding out.
Okay.
Those two are together.
They're together, okay, okay.
So these are updated. They have some new metrics on them and they have updated data on them. So I wanted to talk to you just briefly about the updates. So they added the smoking rate during pregnancy on there, and the social vulnerability index is new on there as well. And then the data source for adult obesity is a different source now. So originally it was a self-reporting data source, and now it's from an Indiana Health Information Exchange data source, which is from physician-gathered data. So they told us that we should expect across the state to see about a 10% increase in that adult obesity rate going from self-reported data to physician-gathered data. And what they're finding is that the rankings are staying the same, but the rates are going up about 10% across the state. The social vulnerability index, I think, is really valuable information for us to know, especially given that we're ranked number 89 out of 92 counties. That includes a lot of different things. It's a really complex, I can send you guys the information for it. It's a pretty complex algorithm, and the more I dig into it, the more I realize how complex it is. But it has to do with stable housing and kind of social opportunities in the area and how we rank as a county. And as you can see, it's kind of low, but I can send you guys, it's a link that you actually go to. And they used, oh my gosh, I'm trying to remember. I want to say they used 2020 data for this, and they're actually the most current data now is 2022 data. Really, really interesting stuff. I know you know a little bit about the SVI.
So we use the SVI on my side for the emergency preparedness, and it helped us target certain neighborhoods as far as where people are that are living on oxygen or have health issues or on dialysis and things of that nature. So it helps us target in on those. So if something does happen, we know who needs electricity first, who needs drinking water first, things of that nature. So it's a great tool and can be used for several different things.
The reason why you have to use a link to download it is because there's hundreds of thousands of data points on the spreadsheet that you download online. So there's a lot of stuff in there.
Do different vices also fall within that SVI?
I don't know.
What is it?
Vices?
Yeah.
Is that what you said? Vices? Like smoking rates?
Like people's vices?
Yeah, narcotics and those type of things.
Not typically.
Okay.
It's usually something that has hard data with it, and it'd be hard to nail that one down.
Yeah, I think it's more environmental or like availability of things in the area.
It tells us where the unemployment is. It tells us where people are insured, uninsured, things like it. Of course, you're relying on people reporting this data too. So.
Like average household income, things like that.
Complexity of this.
Yeah. Then the last thing kind of related to data and Health First Indiana and all that is this one. This may not be paper-clipped together, but it would be probably directly after what you have, yeah. So this is a one-pager that, well, it was supposed to be a one-pager that the Indiana Department of Health created for legislative support purposes. So this kind of talks about our funding, what we're doing, our success stories, our partners, stuff like that. So it's kind of a nice little snippet of what we've got going on with our funding. Talks about our funding for 2025, so you kind of see there that is the number that we use on the budget that we approved. So that's nice. Check. Yeah, and exciting too, kind of looking at it. So you can see our sub-grantees are listed there too. They had Hoosier, trying to remember, they told us specifically what the day was called, like Hoosier Help Day or something like that, where they had legislators come in and they used these to present to them about how awesome we're doing, and this is what they use. So I wanted you guys to be able to see that. Financial report, so that's your next little spreadsheet here, and that is your light blue tab. And so this is the same format that we used the last time we did a financial report. So across the top, you'll see the labels for the various columns that we have, and then I've numbered the different accounts on the left-hand side so that we can kind of all stay on the same page if you guys have any questions. And then Brittany's got some notes over here for us on the right-hand side if there's any, maybe anything going on with those accounts, things we're following up on, things like that, things of that nature. So if you go to the fourth from the right-hand column says available funds. That's where you can kind of see what our status of that fund is compared to, let's see, 1, 2, 3, 4, 5, the appropriation amount. So those are the ones that we're really wanting to kind of compare to each other, our available funds versus what we originally appropriated for those accounts. So you can kind of see how we're tracking along, and the cycle is in between those two columns. So I'll let you guys take a look at it. I'm not going to go over it in huge details because I know that'll bore you guys to tears, but if you have any questions, I'm happy to answer them right now.
Naturally, your funding will go over if you don't use it.
Yes, yeah. In some of these accounts. Some of them, if they are like reimbursable grants, so we spend the money, then we apply for reimbursement with the state. So you would have to check out like the cash column, for example, to know exactly what's in our account right now.
So for
Does that make
example,
sense?
Number 5, the syringe donation fund, that's appropriated $30,000, you still have current cash.
Yeah. That one's actually a check that we get from Reed at the beginning of the year, and so there's some rolled over from last year and then our check from this year too.
I know after approving a lot for the Health First, so we still have a substantial amount that we need to spend.
Yeah.
So just keep that on our radar, like how are we gonna spend it?
Yeah, I was gonna, at some point, probably once we get through the county budget process, talk with you guys about what you think might be the next step for the next contracting process. If you wanna shoot for maybe a 12-month contract starting January to December of 2025, so that, I'm glad you brought that up, maybe start mulling that over in your minds, what that's gonna look like.
Any further questions, comments? Thank you.
And I'm always available to answer questions afterwards if you have a question on down the line. Okay, so staffing updates. Independent contractors have been a big topic. There was a Fair Labor Standards Act change in March. Ron and I have been in kind of some communication about what that looks like as far as the health department and our contracting future, and we're in the works. So I organized this agenda before Ron and I kind of decided what our upcoming meeting situation looks like. So just to give you some background, the yellow tab here summarizes the Fair Labor Standard Act's change that happened with what's called the economic realities test. So I'm sure we will be talking about this in the future, so just so you guys have something to refer to in the meantime, that's what this fact sheet is. It's just kind of a summary of that information. I did want to talk to you a little bit about some of the contractors that we have right now and their grant cycles that they are in. 4 of the 5 of them are funded by sources that are ending at the end of the month and will roll over into new cycles in July. So one of them has a significant amount of comp time, which is not supposed to happen. They're not supposed to be offered comp time as contractors. That was something that happened before I was in charge of their time. And so what I kind of want to get a feel for is the group's thoughts on doing like a comp time payout. And it would be out of the school liaison fund. So we know that we have a significant amount of money in that fund. This individual has, I would say, somewhere between 30 and 40 hours of comp time. And in order to kind of keep staffing stability, it would be my preference, my recommendation to do the payout. But I want to get the board's feel on that.
Now, this person is a contract person, and it was under the former.
Yeah.
And, okay, so my understanding also is that we're kind of in a never land as far as the contract with those people.
Yeah. We're working at those details right now, kind of behind the scenes, what that's gonna look like.
Becca, the comp time, I mean, obviously, we're dealing with something that makes no sense.
Yeah.
If it's a truly independent contract. I would say that let's make sure we mitigate the comp time by not treating anything as overtime, because it's so it'd be
That's gonna be
straight
my question.
hours. We had these independent contractors that were paid on an hourly rate basis, but they should not have been. I don't know if they were not given premium time under the Fair Labor Standards Act if they work more than 40 hours in a defined period of work week, which again, the whole issue is one that has historically been problematic for the health department, and one that I don't believe has been properly handled. But the nice thing is, with every year that goes by, the statute of limitation kicks another year, and so we're a year safer. But I commend Becca. She's trying to get this straightened out, and I'll help her as best I can. Having said that, I have to tell you that I don't believe the risk tolerance for the commissioners or the council is that great. So I think if there's going to be any doubt at all, they're going to want us to err on the side of caution and use bona fide independent contractors. The easiest methodology is to have an entity that we contract with that hires the people themselves to do our contracted work. And we've had that model in the past. It had problems for reasons not related to this dynamic. But short term, I think there is the possibility of going to the service agencies, if you will, manpowers, and there are probably others, but that's more generic, like Kleenex now, I think. But under the fact that we're probably not getting around the employer status, we're probably converting that to joint employment in most instances. But the financial risk is mitigated considerably by the fact that Manpower will then be doing the withholdings and the mandatory federal tax withholdings that an employer would do. So even if we're held to be a joint employer, it's fine. The government will have received its due, if you will, and I don't see a risk that. And again, if you're in a bind on a short-term basis, that may be an approach. Again, the other problem with that is I don't know what the market's like out there. It's pretty tight if you're just going out and hiring yourself. So the pool of talent that Manpower or any other hiring agency might have is probably going to reflect the reality of the marketplace we're in right now.
So how much time are we talking? Are there a number of individuals, or is this?
So there's one person right now that is kind of the issue that
Okay.
was allowed to historically build up a significant amount of comp hours.
Okay.
And I've worked kind of diligently to try to get him to work those back down. It should never have happened. He should have never been allowed to have comp hours in the first place. But kind of as we're progressing towards the end of his grant cycle, my concern is I'm not going to be able to get him to use 30-some hours. Yeah. And we do have, financial stability in that fund to be able to pay him a lump sum for those hours. I'll have to get with Ron, get with, whoever are the appropriate entities to discuss what's the legality of that process, because it should have never even happened in the first place. But it was well before my time. And
Okay. And you mentioned, Ron, about this would be at his hourly rate, not any premium pay.
Right?
I mean, sometimes that gets.
I don't think there would have been any reasonable expectation of premium pay now. And if there is, I think we just have to deal with that. I think we're problematic in the situation we find ourselves, so there's no point in compounding it.
Because I know historically, one of the issues I dealt with a lot with the state is used to do that to avoid paying premium pay, give an employee an option that way sometimes, and that's what gets into a whole complex issue, as you mentioned. So anyway,
Well, in the classic comp time, the employer has the right to basically
Right.
insist that comp time be the preferred method of overtime compensation, and that the regs have limitations on how much can be accumulated based upon the type of job you're in. That's not relevant to what we have here, but
I will very generally say in this situation, I don't suspect that will be a problem.
Okay.
In the future, I'm not sure, but in this one, I don't think that'll be a problem.
Well, I would entertain a motion that Becca and Ron resolve this issue.
and there's no issue with using those funds to be able to do that. The funds, where the funds would come from, that isn't an issue.
Not for me, it didn't. 'cause I-
Okay.
Well, it would come
But
from the
it
grant
probably
that
is
this
for
person's been
balancing your
working under,
budget.
I
Right.
think.
Does it come from the,
I didn't know how
that's
it
the
counted.
question I
It
had.
would come from the
Right.
grant that that
Wow.
person's working from.
Okay.
Yeah, yeah,
I know sometimes funds are pigeonholed as
Yeah.
to what you can use them for.
exactly.
Were these originally grant funded positions, Becky?
Yes, and it would come out of the same fund.
Mhm.
This is the one single fund where we actually get to keep the money if we don't spend it. So that's the nice part
Oh.
with this fund too. It's the same fund that we're using to fund our sub-granting with the Purdue Extension and Boys and Girls Club.
Okay.
For a motion to approve.
So moved.
Second?
Second.
All in favor?
Aye.
Aye.
Okey-doke. So we got approval for our immunization program to continue, which is what we get a lot of recognition from the state for, because we have excellent immunization rates in Wayne County, and we have a very thriving program. They actually offered us more money than we asked for with our application, which was interesting. That's never happened to me before. So I have requests to hires, and I think I put those over there with you, Dr. Ryder, maybe just to review. But I've kind of preemptively filled out the request to hires for the, they're currently vacant positions that are part of that immunization fund, already approved county positions. Requests to hires for that immunization grant cycle that restarts on July 1st. We had talked about, when I did that application, to go ahead and redo the part-time public health nurse, because I wasn't sure if we really needed that person or not. And kind of with some recent things, I think it's imperative that we go ahead and get that filled as soon as possible. So as soon as that funding cycle turns over in July, I want to get that position posted. So I just wanted to make you aware
And
of
that's
that.
already a position that's been approved.
Yes, mhm,
It's
yeah.
just filling a vacancy.
Filling a vacancy, yeah.
Existing
Mhm.
vacancy.
Yes. Yeah. And also, this is just to inform you that we did, I want to say it was 149,000 that I applied for, and they awarded us 197,000. So pretty exciting there. Update on our FEMA program. The coordinator, we're still accepting applications and interviewing individuals for that program. That is for an RN. So it's a little bit more difficult to find someone there. So just kind of putting some feelers out there. Our community health worker with our FEMA program, she's a part-time person, and she completed all of her requirements for her community health worker training, and she's now a certified community health worker, so that's exciting. As far as program updates, I wanted to update you guys on some partnerships that we're working on. We are looking at partnering with the Richmond Police Department and Firefly on a car seat safety program. We are looking at partnering on the Wayne County Sheriff's Department on injectable Narcan. I included, I'm not sure even how to say this, Evzio. So there's an insert in your packet here. So this is injectable like an EpiPen. So it's intramuscular, and it injects opioid overdose reversal medication like you would inject an EpiPen in an emergency situation. So the sheriff and I have been discussing opportunity for partnership there.
Is it just a one dose?
It says 2 milligrams, I think.
Okay.
So I'm not really sure, to be honest with you. I'd have to look more
And
into it.
it's got voice guidance on it, which I think can be very helpful in time of crisis.
Mm-hmm. Yeah, like an AED type of.
Mm-hmm.
Yeah, pretty cool. So I'm looking at pricing that out, getting numbers from the sheriff, stuff like that. I think that he wants to have them for all of his jail staff and everyone out on the street. Is that right, Brad?
Mhm.
Yeah. Then the syringe remnant testing, we talked a little bit about that. So Marion County has been doing their syringe remnant testing program for about 4 years now. I've talked with Alan Moore with the Sheriff's Department and kind of collaborating our syringe remnant testing with their remnant testing machine that they have at the Sheriff's Department, and kind of creating a comparison spreadsheet. So what we're going to use de-identified syringes and send one to the state and test one with their machine and kind of compare. Also with kind of some emerging drug trends that we're seeing, we're gonna be looking for some of the substances that are a little bit more, not a little bit more harmful, but very, very dangerous with that partnership as well. Another partnership that we have coming up is with Centerstone, the City of Richmond, Stride Center, Mobile Integrated Health, and maybe Amanda wants to talk about that.
Yeah, so, okay, so SAMHSA awarded Indiana, so CCBH said, Indiana will now be part of the CCBHC demonstration. CCBHC stands for Certified Comprehensive Behavioral Healthcare Clinics. And what that means is, for Indiana, is that 8 community mental health centers were selected, Centerstone being one of them. And these mental health centers will be transitioning to the comprehensive behavioral healthcare model. It kind of changes the way that, you know, we're billing for services, the way that we are providing services, reducing a lot of barriers to folks getting into care. So one of the great things that this will mean for this community and surrounding communities is we will be working with City of Richmond, the Health Department, and the county to develop a Stride Center. It's a model that was started in Bloomington, which will be a crisis stabilization center. And in addition to that, there will be a mobile crisis response team that will be connected with Stride. So we're having some planning meetings in the very near future to start looking at how we all partner together and then, you know, kind of look at developing out a space for that. So very exciting stuff.
Okay, so the next item that you have in your packet is I went ahead and filled out the AmeriCorps application. So we had discussed how I could summarize what we might use an AmeriCorps service site member for, and so I thought that it would be maybe most appropriate just to fill out the applications and highlight some information for you on here. I don't think that it's necessarily relevant for you to read every single thing on here right now, but probably the most relevant information is going to be on the 3rd page. So we're looking at like 15 through about 24, maybe even through 27, where it talks about utilizing them for our harm reduction services, doing community health worker type of work, STI, STD testing, helping with the syphilis issue that the whole state has going on, and all the Hep C initiatives that we have going on as well. If you look at, let's see here, page 6, that's where it talks a little bit about the price breakdown. I told the director of AmeriCorps that I would speak with her more so about what we may be interested in after I had a chance to talk with the board and get a feel for what the board was interested in. And then, it's on the very last page that it gives some common position descriptions, and the directors told me that it's really up to us however we want to label that person or kind of write their job description, I guess. And then Dan had asked about background checks, so I had asked her, and she said they do a national service criminal history check, which includes FBI fingerprint, a state criminal registry check, and the sex offender registry check. And they have to be cleared from the area. If they're not cleared but do not have a murder conviction or sex offense, it's at our discretion to continue with onboarding, and they include the service site within that process. She talks a little bit about educational backgrounds, and they encourage diversity. They have people from MD, MBA, all the way down to GED, kind of everywhere in the middle, educationally background-wise. Spend the first month of their term with different trainings from IDOH, including things like HIV, HCV, and harm reduction testing training. And then each independent member is encouraged to pursue training in their professional goal area. We did talk a little bit about community health worker certification training and kind of that maybe being relevant to what we're interested in.
So you're interested in having a full-time?
I think that it would be beneficial, or that we could use someone full-time.
contract with AmeriCorps to provide this person.
Yeah, and kind of how they relate, so the Health Foundation of Greater Indianapolis was established as a foundation to help fund harm reduction initiatives that are not legally allowed to be funded through the Department of Health. And the AmeriCorps for Indianapolis is a branch off of that. So they are loosely related with the Department of Health, but not specifically associated with the Department of Health, if that makes sense.
And the cost to us?
It would be $8,500 to have a full-time member for 1,700 hours from September 1st through July 31st of 2025. They would be with us for 4 days out of the week, and then they do special projects on Fridays.
So the cost to us is $8,500.
Mhm. Yeah, and I think you did the math last time, and it came out to less than $5 an hour.
Yeah.
Mhm.
So
Right.
are they paying these people?
I know they earn an education stipend, and that's kind of where I thought maybe the $8,500 comes in.
Right, because
Um,
it's pretty large.
Yeah, so they get their compensation is on page 6, highlighted right there in the middle. So they get loan forbearance, health insurance, dental and vision insurance, child care assistance, that $7,400 education award, training, and then some other kind of supportive services.
Well, it sounds like a good deal for us, but if you're that person, it sounds like you're gonna be living on a shoestring.
Yeah. I think a lot of their basic needs financially are covered through the program because of their health insurance and things like that being covered. I'm not really sure how they pay for things like food. I know the service site member that is just spending a few hours a week with us right now through Bridges for Life has a job in the evenings. So that may be kind of how he affords to do that. I don't know that they all do that though.
And they do this to get experience, or what's?
Yeah.
Why does someone want to do this?
So they may be individuals with lived experience as far as like substance misuse, and so it kind of helps establish them professionally in a certain area. I know that that's the case with the individual that we're hosting right now, but I'm not really sure what the motivation is for everyone.
I don't think there's any reason not to do it. So, need a motion to approve and going for full-time?
Yeah, I think so. I think because it's a contract, I'll have to take it to the commissioners.
Commissioners.
You just want one for now. I'll make a motion to approve.
Approve.
Second.
All in favor?
Aye.
Aye, opposed?
Really quick update on lead. Actually, I don't have a lot to update because I had to jump off of that meeting to come to this meeting this morning. So the lead requirements for screening in children changed at the beginning of 2023, but the lead funding went down in the state of Indiana. And so the Indiana Department of Health has kind of addressed that frustration, and they were addressing that in a meeting this morning as far as with the KPIs required with Health First Indiana, with the additional lead screening and lead requirements imposed with the Indiana code, and kind of all the changes happening, they felt that it was something that they needed to address, and that was happening this morning. So while I don't have updates for you right now, there were updates that were happening this morning. So I'm going to go back and watch the remainder of that meeting that I was on this morning, and I'll provide you some more information on that after I get all the details. I do know that my public health nurse and I think my lead environmentalist risk assessor was on that meeting this morning too. Just a couple more miscellaneous things. We are going to be at the Wayne County Fair, and we got some fun marketing stuff. We're going to have employees rotating shifts with coverage of clinical and environmental team members at all times. The logo wear stuff that we talked about before got put on the back burner for now with all the Health First Indiana sub-granting stuff taking priority. Our conference room is moving along. We are painted now and we're working on furniture. And then quick medical update in Wayne County. We have an active tuberculosis case that we're working on in Wayne County right now. We're in the process of case investigation. We're working closely with the state, communicating, I would say, 3 to 5 times a day. Working with the employer, offering testing at the health department's cost. That's kind of part of a reserve that we keep when they work at an employer that has a significant amount of employees. The State Department of Health has kind of coached me on what to say in a public meeting, so I have to keep things kind of vague right now, but essentially that is progressing. It's being worked on, and as of right now we have 1 active TB case throughout the case investigation. All right, Dan, you're up.
Again, mine's not as long. So the mobile unit is down again. I have it over in Newcastle at Walnut Ridge, repaired. I've not yet received a call as to let me, it's leaking sewage. So I think it's a gate valve, but not positive. Hopefully I get that call today. I presented before the Realtors Association last week at Forest Hills. It went really well. So I've had a couple more invites. I went to one of those this morning, presented again for about an hour and a half. As Becca stated, the fair starts. Technically for us, it starts on Friday with inspections. We have about 46 food vendors signed up right now. And then part of the core services is tattoos, body piercing, eyelash extensions, some of the new ones, programs that we don't already have in place. I'm working on ordinances for those, especially the tattoo and body piercing. I am working with a tattoo artist as an advisor. I've spoken to about 3 different tattoo artists, and they want an ordinance. They want this to encourage, so they don't have people in garages giving tattoos and stuff. I won't get in too much detail because, like I said, I'm using his as an advisor, and I've got a lot of updates now. It will probably change by the time I present it. So, and then I've written 8 different, probably 9 different standard operating procedures. And that's per the KPIs. They want us to have procedures in place, documented. So I'm going to ask this board, how do you want to receive those? Surely not all at one time. Do you want 2 at a time? Do you want them in electronic form, paper form?
I'm okay with electronic.
Yeah.
Me too.
Okay, well, let's show a hand. Electronic? Paper? Okay.
Electronic form, I can send them all to you, then you can take your time and read them and converse them. We'll set maybe a couple months out. I'm in no rush. They don't have to be approved next meeting or whatever. So that's all I have.
Under new business, I talked to Dave and Jeff Plaster, and it occurred to me that it would probably be beneficial for the county, the councilors, and the commissioners, and this board to kind of meet at a workshop and kind of discuss where we are and where we want to be going, and try to get on the same page. Because I think over time there's been, this department's had several ups and downs, particularly sometimes with the elected officials. And I think it would be good if we just kind of sat down with everybody involved and discuss what we're doing, what we'd like to do, and get their impressions.
Sure.
So what that would mean is probably an evening meeting. I think it would probably end up still being a public meeting. Is that?
Pardon?
Would it end up being a public meeting, a workshop? So I think it would be a public meeting.
Be a public meeting, that does, public can observe it, whether you have public input or not. I think this is more like what I would call a work session,
Mhm.
to kind of talk about your missions, respective missions, and how they intertwine, and so that they're hopefully common understandings and expectations. But it would be a public meeting.
But any objection to doing so? And I will speak to, I think Jeff's going to spearhead helping get this set up. And Dave, you're on.
Well, first of all, I want to apologize for everybody for my lateness. It reflects on the age of my brain and not your importance. But I'm sorry to show up late. I'll start my health report. This is a change up today. Normally I start with some sort of respiratory disease. And when I first became health officer, that first month there was a syphilis epidemic in Indiana. So
Oh, no. Are we circling
we have a
back?
syphilis, yeah, it's a gift that keeps on giving. Anyway, the state has a data dashboard for syphilis. So you can get your syphilis information in a timely fashion. The state syphilis cases are declining over the past 2 months. Unfortunately, Wayne County is not following this overall trend. We saw a decrease during the first quarter of the year, but of about 60 to 80%, but 100% increase in cases during the month of April and May. As far as congenital syphilis, 9 out of 10 of these cases could be prevented by treating the mother. Unfortunately, about 40% of the mothers are not getting prenatal care. They're not being tested for syphilis, and so they're not being treated. This could be devastating to the fetus if the disease isn't treated because of significant morbidity and mortality. The Wayne County Health Department plans to expand our STD, STI testing as well as pregnancy testing through our harm reduction program. Also, the CDC has suggested that people be given so-called post-exposure prophylaxis, which consists of doxycycline. In this approach, people that would be able to self-administer doxycycline as soon as possible after sex to prevent syphilis as well as chlamydia and gonorrhea. Medetomidine, a drug you probably have never heard of unless you're a veterinarian, has made its way. This is a common sedative and analgesic used by veterinarians for treating dogs, and now we're starting to find it in the syringes of drug users. The overdose signs are similar to opioid, the main one being respiratory depression, which is usually the cause of death in an opioid overdose. All of these people should be given naloxone, but this is not an opioid. It's a sedative tranquilizer type drug and will not respond to the naloxone. However, the people that are in a crisis probably have other drugs mixed in with this. All of these drugs that people are getting are more like cocktails of various opioids, tranquilizers, and
Amphetamines, all of it.
exactly.
Mm-hmm.
So anyway, the naloxone, anybody that needs naloxone can get this for free by coming into the Wayne County Health Department. We haven't seen this in Wayne County, but as you know, it will probably occur sometime in the future, and we need to be cognizant of it. And that is my health report.
Thank you.
You're welcome.
Any further questions or comments? Next board meeting, July 16th. Any other comments, questions? Entertain a motion to adjourn.
So move.
Second?
Second.
Second. All in favor?
Aye.
Opposed? Thank you, everyone.
Thank you.